Good evening to all of you, respected senior colleagues and my dear junior colleagues. First of all, I thank Dr. GVK for giving me this opportunity. So this OSA, obstructive sleep apnea, actually this is a most neglected topic in many of the conferences. Only very few conferences they highlight about this. And we have to thank the scientific committee for giving me this opportunity. And my flow of talk will be like this: introduction, prevalence, importance, this list important. Is there a link between sleep and OSA and diabetes? Yes, definitely. Sleep and diabetes are closely related, and OSA and type 2 diabetes are interacting epidemics. So like as diabetes is exploding and the OSA is recognized a lot in the recent past after the increased incidence of obesity in the diabetic people. We all know just to the basic non-rapid eye movement sleep and rapid eye movement sleep, this just recollecting from our first MBBS days. And one question everyone will have: duration and quality of sleep, is it important? Yes, definitely. According to this meta-analysis of prospective studies, you look at this. This study concluded a U-shaped relationship between sleep duration and the risk of type 2 diabetes. That is U-shaped relationship. What is U-shaped? Suppose, imagine, if sleep is prolonged compared to 7 hours per day, if it is 8 hours or 9 hours, oversleeping, laziness, it increases the diabetes risk by 9%. And an hour decrease in sleep, that is less than 6 hours, it increases 9% increase in diabetes risk. And an hour increase of sleep duration was associated with 14% increase in diabetes risk. So always we doctors, we usually tend to neglect this factor. So this has been proved by this meta-analysis for based on the various studies. And these are the spectrum of sleep disorders, starting from basic one, snoring, which every one of us will have. And the second one is upper airway resistance syndrome, which is called as UARS. And the final one is OSA, obstructive sleep apnea. There will be overlap between these three. And this is the best definition I have referred from various journals. So OSA is characterized by repeated pharyngeal collapse in sleep with apnea spell of more than 10 seconds, resulting in cyclical hypoxia and sympathetic stimulation and release of stress hormones. So because of this hormonal imbalance, we get the major thing. This is normal anatomy physiology. Normally during sleep, the muscles which control the tongue and the soft palate hold the airway open. Okay, look at this. If these muscles relax, look at that, airway narrows, causing snoring and breathing difficulties. If it is worsened, if these muscles relax too much, the airway can become completely blocked, preventing breathing. This is what happens in OSA. So these are the risk factors for OSA. Obesity, not all OSA patients are obese, but non-obese patients also can have obesity. And age more than 65 years, many number of patients have OSA. There is little male preponderance when compared to females. And it's usually running in familial. The OSA run in familial. And in heavy alcoholics, this OSA is very, very common. And sleep deprivation usually lead on to this OSA. And in addition to these common risk factors, the additional risk factors are craniofacial abnormalities inherited from birth and pharyngeal muscle hypotonia, largely due to aging and sleep deprivation. So these are the craniofacial abnormalities. Number one is retruded mandible, retruded maxilla, and inferiorly positioned hyoid bone, short neck, macroglossia, there is big tongue syndrome, and neck girth more than 43 centimeters in males, more than 40 centimeters in females. This is a typical example of macroglossia, and this is an example of retronathia. Let us see what is happening in the apneic spell of 10 second or 15 second. So, in the early, BP will be normal. As the middle, that is after 5 seconds or 7 seconds of apneic spell, the BP slowly goes up and heart rate slowly goes up. Of course, the carbon dioxide level also goes up gradually. At the same time, look at the vagal tone, it is slowly coming down. So this is what happening in the apneic spell. As apnea prolongs more than 10 seconds, there is increased sympathetic tone and increased catecholamine release and increased elevated blood pressure and everything. So only the OSA recognition and treatment is very, very important. Let us know the classical clinical features of OSA. We can divide into two. One is nocturnal and daytime. These are the nocturnal. Snoring is very common. And witnessed apneas and dyspneas by the family members, by the spouses usually. Choking, restlessness, constantly changing position in the bed. Nocturia, acid reflux, heavy sweating in the midnight, and of course, frequent dreams. This severe OSA patient, they have this posture to relieve this OSA obstruction. And look at this daytime features. So these are sleepiness, fatigue, exhaustion, morning headache, poor concentration, attention, depression, personality changes, hyponatremia, and all these daytime features of OSA lead on to industrial and increased road traffic accidents. So we should catch them and treat them properly. In women, it's more producing more depression, social isolation, leads on to amenorrhea, dysmenorrhea. And these are the other major consequences like hypertension, ischemic heart disease, cardiac arrhythmias, ischemic cardiomyopathy, stroke, and psychiatric depression, bipolar disorder. Everything can be a consequence of OSA. And this study has proved that there is hyperinsulinemia as well as hyperglycemia after this repeated sleep apnea episodes. There are other minor consequences of OSA like dementia, which is reversible, erectile dysfunction, which our Dr. Deepak Jumani is going to highlight in the next session, and fatty liver, prolonged convalescence in any disease, and venous varicose veins, deep vein thrombosis, and idiopathic bilateral pedal edema, venous edema, and Schamberg's purpura. So these are the things. And these are the factors which aggravates OSA. There are sleep deprivation, sedatives, supine position, heavy alcoholism, use of tobacco. Coming to the prevalence, it's a common but underdiagnosed. So higher in obese individuals, there is increased prevalence. There are many studies which was, as it is published in Diabetes Care, Gary Foster et al., they reported 86% of diabetic patients, those who are obese, have OSA. It's a very huge number. In the other, which is published in Thorax Journal, Westett et al., they showed OSA in men as 23. This overall, not only in diabetic population, 23% as compared to 6% in community-based population, whether diabetes, non-diabetes, both included. And these are our Dr. Vijay Vishwanathan has studied, these reports are high prevalence of OSA among people with type 2 diabetes in tertiary care center. It is 23.65% OSA higher in diabetic patients. So these are the recent meta-analysis of 24 epidemiological studies. It shows 9% to 38%, specifically ranging from 13% to 33% in men and 6% to 19% in women. This study was done by Sanaratna et al. These are the risk factors we have already covered. Of course, the pregnancy and obesity, this also gaining momentum. So the sleep disordered breathing, it leads on to hypertension, leads on to preeclampsia, adverse fetal and maternal outcomes, and lead on to low birth weight babies and fetal abnormalities. And we should encourage breastfeeding because breastfeeding enhances the proper development of swallowing action of tongue, proper alignment of teeth and shaping of hard palate, which may prevent, in some of the studies proved this. So babies, those who don't breastfeed, in future they have more chances of getting OSA. So it's a chicken egg story. Which comes first, obesity or OSA? Both, it's interlinked. OSA produces reduced physical activity, insulin resistance, increased ghrelin levels, and diminished this adiponectin. And obesity increases fat deposit in UAV lumen, reduced tracheal traction, and fat deposit in UAV muscle. So the OSA can lead to obesity by several mechanisms, as I mentioned earlier, changes in leptin, ghrelin, and orexin levels, sympathetic stimulation, deficient rapid eye movement sleep, and reduced physical activity, ultimately leading on to insulin resistance. These are the other CV effects: hypertension, arrhythmias, stroke, insulin resistance, and type 2 diabetes. So both obesity and this OSA and diabetes have bidirectional relationship. So this is the link. So OSA lead, as I mentioned earlier, increases ghrelin and diminished leptin, lead on to obesity, intermittent hypoxia, lead on to sympathetic overactivity, oxidative stress, systematic inflammation, increased interleukin 6 and tumor necrosis factor alpha, and other adipokine dysregulation, and everything lead on to diabetes. How will you diagnose? This polysomnography is the gold standard. It involves EEG leads, ECG leads, that plasma, this myotrophy and everything, and apnea, complete cessation of airflow for at least 10 minutes, and hypopnea, airflow decreases by 50% for 10 seconds. So this will be picked up by polysomnography, and the number of events per hour is reported as apnea hypopnea index, that is AHI. So look at this, AHI less than 5 is normal, 5 to 15 is mild OSA, and moderate is 15 to 30, more than 30 is severe OSA. So coming to the management, primary goal we should give is quality of life, improve the quality of life. So we have to suspect OSA. There should be high clinical suspicion and confirm diagnosis with the polysomnogram, and treat OSA and prevent progressive beta cell failure. And of course, management is basic thing for any disorder, lifestyle modification. CPAP is the gold thing, gold standard. Oral devices, which I will come across later, some of the minor surgical procedures. So lifestyle factors, you all agree with me: weight loss, avoiding alcohol, stop smoking, that is very important, and exercise, that daily exercise, very important. The CPAP is the gold standard. It improves outcomes. So only drawback is cost and lack of awareness and lack of motivation. This is very important. So this is a patient on continuous CPAP therapy. So some people find it very difficult. But some people, they travel. While in the train travel, I have seen many people, they will be using the CPAP machine. So encouraging people with moderate to severe OSA to use CPAP devices can be challenging. And 8% of people who use CPAP devices stop using them after the first night itself. First usage itself, they stop it because of the inconvenience. And 50% of people with moderate to severe OSA stop using their devices in the first year. Only severe OSA people, they continue to use it because they suffer a lot. But the 50% of people moderate to severe OSA, we have to target them to prevent the later metabolic disorders, complications like obesity and diabetes. So recurs counseling and behavioral change in sleeping habits. So some of the oral devices, mandibular advancement, and these are some of the medications have generally not been a part of primary treatment. However, the GLP-1 receptor agonist, that is tirzepatide, has been approved for the treatment of moderate to severe OSA in adults with obesity. So this is a paper, this tirzepatide phase 3 clinical trial. In the present trials involving adults with moderate to severe OSA, the AHI decreased significantly by up to 29.3 events per hour. Yeah, 58% change from baseline. So this is the advantage of using this tirzepatide in OSA patient. Subsequently, after seeing the result, FDA approved the drug tirzepatide for treatment of OSA in December 2024. Other medications are in the daytime somnolence, which will be alleviated by central nervous system stimulants like modafinil, armodafinil, and solriamfetol, and a dopamine norepinephrine reuptake inhibitor may be considered for adjunctive use. There are some surgical, the final few slides. The surgical procedure, that is uvulopalatopharyngoplasty, that is abbreviated as UPPP, that is UP3, is a type of sleep surgery, palatal stiffening and relocation pharyngoplasty, and palatal advancement pharyngoplasty, septoplasty. These are the common surgical procedure. In olden days, when the severe OSA patients, tracheostomy even was done in some patients because they suffered sleepless nights. So this is a mandibular advancement split, MAS, designed to hold the lower jaw slightly down and forward relative to natural relaxed position. So this will easily, we can prevent surgery or any other medication. So this is a mouth guard used by these rugby players as well as the boxers. This also can be used, and some of the specialists, they advise this. Meta-analysis of 51 randomized controlled trials investigating effect of CPAP and oral devices on BP found that oral devices were equally effective as CPAP devices. So take-home messages, it's a common but serious problem. Strong association between OSA and the metabolic syndrome. OSA in pregnancy should be recognized and treated for the well-being of fetus, and recognition of OSA in clinical practice is much. Individualized management of OSA by CPAP and other GLP-1 receptor agonist is a must. So with this, I conclude my talk. Thank you for the patience.